Okay, so we're going to go ahead and get started. Hello and welcome to Attestation Healthcare Solutions webinar. Today we're going to be presenting the Meaningful Use Objectives and Hardship Exception Clarification. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for Attestation. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, for those of you who aren't familiar with Attestation, I wanted to share a bit of who we are with you. We've been in business as Attestation since 2003, but we were NextGen users way back in 1997, EPM version 2.3. We specialize specifically in NextGen healthcare. Our development team knows how to get data into, out of, and around NextGen to customize it and tailor it to meet our clients' unique needs. Our purpose in life, the reason we exist, is to create delighted clients by helping them get the absolute most out of their NextGen software investment. It's our passion to provide solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We really do everything NextGen, from consulting to hosting, customization to support, and we have two NextGen add-on productivity solutions, ChartGuard and Reflex Manager. We're here to help. Next, I wanted to bring your attention to some of the upcoming webinars we'll be offering. On February 24th, we'll be digging deep into using NextGen Share in the real world. In it, we'll look at why interoperability is important and how using NextGen Share in the real world can help you add the goal of nationwide interoperability. We'll provide an overview of NextGen Share functionality, as well as how to set up NextGen Share for your practice, what NextGen Share is used for, specifically CDAs, and how a user can access it, both from medical summary utility and referral template. We will go over direct messaging capabilities between providers and the message directory and walk through EHR referral workflow. Future webinars will also cover the steps to a patient-centered medical home and quality care program reporting. You can either register now or on our website. Keep your eyes out for the webinar invitation email from us. Okay, so back to meaningful use objectives and not hardship exception clarification. Hardship exception clarification. At the end of the presentation, we're going to open the floor up to questions from you. We'll answer questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we'll also be emailing links to a recording and a PDF of the presentation later this week, as we do with every webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning and Cindy Kincaid. Lindsay Lanning originally joined us from the Ohio State University intern program, where she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Cindy Kincaid is Vice President of Consulting Services at Attestation and a Certified Practice Management Executive. With over 25 years in the IT healthcare industry and 9 with Attestation, her experience runs wide and deep. This makes it possible for her to provide the insights needed to help healthcare organizations experience great success no matter what the challenge is. Okay, so Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great, thank you, Chelsea. Hi, everyone, and thank you for joining us today for our webinar regarding meaningful use objectives and the hardship exception clarification. It's hard to believe that this is our third webinar since the release of the final rules for Stage 2 and 3 only a few short months ago, but they truly are necessary due to the countless updates, clarifications, and changes made since then. This webinar will act as a follow-up to our previous meaningful use Stage 2 and 3 final rule presentation. So while we don't plan on going through each objective and associated measures, we will highlight significant changes with hardship exception standards and clarifications of public health reporting requirements, as well as overall program updates. Together, we're going to analyze the ever-changing mandates and explanations associated with meaningful use since its release in October. And our hope is that by the end of this webinar, you will feel confident in your knowledge regarding the immediate future of meaningful use and fully understand the changes and updates that CMS has kept stacking up on us over the past 4 months. So in today's webinar, specifically, we will look at Objective 10, Public Health Reporting and its measures, Registry Basics, really defining what a registry is and the differences between the registries mentioned in the final rule, how to achieve public health reporting through registries. So looking at what options providers have through NextGen, interfaces, data extraction, and other options we've come across in our research. public health reporting exclusions, so differentiating between standard exclusions and alternate exclusions. Meaningful use hardship exception, so what this is and what this new legislation means for providers. Other miscellaneous MU updates, and finally the future of meaningful use, which is gaining a lot of attention after a speech made by Andy Slavitt regarding where the program is headed. So let's start by looking at meaningful use public health reporting. The public health objective, taken straight from the modified Stage 2 final rule, states the EP is actively engaged with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using CERT, except where prohibited and in accordance with applicable law and practice. The measure states the EP is required to successfully attest to any combination of 2 measures from 3 available. So that's immunization registry reporting, syndromic surveillance reporting, and lastly, specialized registry reporting. And notice that you can count specialized registry reporting a maximum of 2 times toward the objective as long as they are different registries. What this means is you can have any combination of the following measures in order to successfully attest to this objective. So that's immunization registry reporting and syndromic surveillance reporting, immunization registry reporting and specialized registry reporting, syndromic surveillance and specialized registry reporting, and finally specialized registry reporting and a different specialized registry. So an EP who is scheduled to be in Stage 1 in 2015 must report at least 1 measure unless they can exclude from all available measures. And Stage 2 EPs must meet at least 2 measures in 2015. All EPs must meet at least 2 measures in 2016 and 2017. This means for this year and next, there are no more alternate exclusions for providers. Everyone, no matter if you're new to meaningful use or returning, everyone is now considered on this modified Stage 2 and has to meet 2 public health reporting measures. Also, keep in mind, this is a self-attestation objective, so you must attest yes, you are in active engagement with any combination of the 2 registries we just went over, and keep all supporting documentation in your own audit binder. So I keep saying this phrase, active engagement, and highlighted it in the last few slides. But what does it mean, and why should we care? Well, in order to successfully meet the public health reporting objective, a provider must be in active engagement with a public health agency or a clinical data registry. Originally, the objective used the verbiage ongoing submission, but changed it in order to better capture a physician's actions. So how does it better capture a physician's actions? Well, to be considered an active engagement, a provider now has 3 different options. Option 1, completed registration to submit data. Registration was completed within 60 days after the start of the EHR reporting period, and the EP is awaiting an invitation from the PHA or CDR to begin testing. Registration to 2 public health agencies or specialized registries needs to be completed by February 29, 2016 in order to meet the deadline to achieve active engagement in 2016. Once you have registered your intent with 2 registries before February 29th of this year, you are successfully meeting this objective. Just make sure to respond to any requests for information throughout the year. So that means if you've already done this previously for meaningful use at an earlier stage or last year, it still counts. You just need to have registered your intent to submit data to 2 registries by February 29th. It doesn't matter when you registered, just that it's done and you haven't missed any communication from them. Because if they reach out, you have to respond, and if you fail to do so more than 2 times, it no longer counts toward the measure. So make sure someone is monitoring whatever contact information you gave the registry to ensure there are no miscommunications from them. And then there's 2 other options that are considered active engagement as well. And they are option 2, testing and validation. So the EP is in the process of testing and validation of the electronic submission of data. EPs must respond to requests from the PHA within 30 days. Failure to respond twice within a reporting period would result in failure to meet this objective. Again, we see this communication stipulation. And option 3, production. The EP has completed testing and validation and is electronically submitting production data to a PHA or CDR. So just to clarify, Under the active engagement requirement, providers would only need to register once with a public health agency or a clinical data registry and could register before the reporting period begins. In addition, previous registrations with a public health agency or clinical data registry that occurred in a previous stage of meaningful use could count toward active engagement option 1 for any of the EHR reporting periods in 2015, 2016, or 2017. Again, I really want to drive this point home since there's been a lot of confusion surrounding this. Providers who have previously registered, tested, or begun ongoing submission of data to a registry do not need to restart the process beginning at active engagement option 1. The provider may simply attest to the active engagement option which most closely reflects their current status. So we've gone over the objective and measures for public health reporting, and we keep saying you need to pick 2 registries. Well, I'm sure at least some of you are wondering, what are registries? As defined by the NCVHS, a registry is an organized system for the collection, storage, retrieval, analysis, and dissemination of information on individual persons. Registries are operated by federal, state, and local governments, universities, nonprofits, private groups, etc. So let's take a look at some key characteristics that distinguish registries from other technologies. The use of a registry is distinct from an EHR. The EHR is a point-of-care essential, recording patient information and maintaining patient history, while the registry has a long-term focus in measurement and improvement. The EHR collects data directly from providers. While the registry has an input mechanism, most data is collected from the EHR, not the provider. The registry audits, validates, analyzes, and reports data. The registry aggregates data from multiple sources, collecting information from multiple EHRs and providers. And its purpose is, again, long-term versus point of care. And lastly, registries are focused on measuring and improving outcomes over time. And they do this in order to meet various programs and client requirements. Now, a trend we've seen over the last couple of years is that reporting data to a public health registry has been moving from paper to electronic media and transition of data, from periodic batch uploads to real-time updates, and from one-way transfer to bidirectional exchange. So the registries we will talk about today include clinical data registries, public health registries, and specialized registries. First off is the clinical data registry. And this type of registry collects clinical data to track care and outcomes of a specific patient population. It has many purposes. To name a few are it focuses on health problems, benchmarks performance and feedback to providers, and identifies care gaps. But overall, the purpose is to provide more information in order to improve care outcomes and care coordination. A CDR truly enables providers to identify patients with gaps in care and contact them between visits to urge them to get a recommended test or treatment. It provides physicians with feedback on how well they're managing their patient population and helps them adjust their care. Next, we have a public health registry, which is a registry that is administered by or on behalf of a local, state, territorial, or national public health agency, which collects data for public health purposes. So while immunization registries are a type of public health registry, CMS kept immunization registry reporting separate from the public health reporting measure to retain continuity from stage 1 and 2, in which immunization registry reporting was a distinct and separate objective. And I did just want to point out that every state should currently have an immunization registry up and running, and you should refer to your state's website for more information on it. And finally, we will look at specialized registries. In CMS's words, a variety of registries may be considered specialized registries, which allows providers the flexibility to report using registry that is most helpful to their patients. We will continue to allow these registries to be considered specialized registries for purposes of reporting for the EHR reporting periods in 2015, 2016, and 2017. Under the meaningful use rules, a specialty or specialized registry could be one created by any of the specialty societies or other quality stakeholder groups. While the rules don't go into many specifics about what constitutes a specialized registry, CMS does say this. In the Stage 2 final rule, we were purposefully general in our use of the term specialized registry to encompass both registry reporting to public health agencies and clinical data registries in order to prevent inadvertent exclusion of certain registries through an attempt to be more specific. Basically, they were afraid if they got too specific, they would be excluding possible registries that providers could use to fulfill this measure. So let's get into the specifics of how to achieve registry reporting and look at options available to providers today to submit data. I'm going to go ahead and turn it over to Cindy Kincaid for this section. Cindy?
Okay, great. Thank you. So as we move into registries, I want to talk a little bit more about how you can really accomplish getting connected to a registry, not necessarily achieving it, but getting connected to it and to accomplish achieving it. So the first thing we'll talk about is the NextGen Clinical Registry. The NextGen Clinical Registry Services utilizes NextGen Share to allow access to the following registries: the American College of Physicians Genesis Registry, the American College of Physicians Diabetes Registry, the American College of Physicians Immunization Registry, the American Academy of Allergy, Asthma, and Immunology Clinical Data Registry, Oncology Nursing Society Quality Improvement Registry, American Joint Replacement Registry, Orthopedic Quality Resource Center, American Gastroenterological Association Clinical Data Registry, National Osteoporosis Foundation Quality Improvement Registry, and Renal Physicians Association Kidney Quality Improvement Registry. I just really wanted to see if I could read all of those, and I've actually made it through much better than I thought I was going to. While there's no cost to use NextGen Share, subscription and/or participation fees apply. The costs vary depending upon the individual registry, and you'll need to reach out to your NextGen sales rep, or if you work directly with us, and we can get you the rates on what those annual fees are associated with those particular registries. The first step, though, is to register your intent with the registry of your choice to satisfy any applicable registry fees. So a NextGen frequently asked question. According to a NextGen published FAQ, NextGen Clinical Registry Service provides the capability to connect to specialized registries and meet Measure 3 of the public health objective, but cannot be used for immunization or syndromic registry reporting at this time. So those are not interchangeable, and we've had that question quite a bit, and clearly so has NextGen. So how does it work? NextGen states interfaces to the individual registries will be self-installable and configurable from the NextGen Share portal. Now, we all know that that may be true, although if you've tried to set any of these up, you can find that some of these really take a little bit more work and are not quite as easy and out of the box as we would hope they would be. And a lot of that depends on the registry itself. Depending on, it varies from registry to registry, and some of these can be much more complicated to set up and require a lot more testing. The NextGen EHR will export a CDA for each patient upon encounter lock and send to NextGen Share for registry submission. And that's really important. It creates a CCDA when the encounter locks, and then it uploads it to the Share for registry submission, much like it does to the portal if you're sharing those with the patients. The CCDA will be evaluated for measure compliance with each registry your providers are signed up for. Providers will also have the ability to log into a portal and track their progress for quality submissions with each registry. If NextGen Share is not available for, or does not support the particular registry, you may require an interface. And what that does, the registry does not accept data extraction upload other than an interface may be required. These registries require data to be submitted on a regular basis through an HL7 interface. Some of these are the immunization and syndromic NextGen interfaces. There's also a cost with building an interface, and there can also be a cost associated with the actual Rosetta HL7 agents that you have. We've done a couple of these, and I can tell you there are also some other ways around it, particularly with various states and immunization. Sometimes you can do a manual upload, and you can avoid some of those interface costs, but there's still a lot of effort associated with it. There are registries available that do not utilize NextGen Share and therefore do not have a direct relationship with NextGen and also do not require a commercial interface. Instead, these registries enable data extraction by working directly with the practice and are available to clients outside of NextGen Share. And a couple of these are the American Neurological Association, the American Academy of Neurology, the American College of Emergency Physicians, the American Board of Family Medicine, American College of Rheumatology, the American Society of Nuclear Cardiology and Image Guide, Academy of Dermatology, Diabetes Collaborative Registry, American College of Cardiology, and the American Academy of Ophthalmology. What this means is that you can work directly with these entities and get data out of your system without utilizing next-gen share or anything. Typically it's an upload or sending a report. There's a lot of different ways that you can do it if you've worked with any of these. And then there are other specialty registry options. If you're a specialty practice struggling to find a specialized registry, there are some other options available to meet the specialized registry reporting measure. There's DARTnet, and it's a patient safety registry. There's National Healthcare Surveys and National Ambulatory Medical Care. In the white paper for Objective 10 Public Health Reporting, NextGen lists these registries separate by type and states where they're available in each state. If you would like a copy of these white papers, and we'll mention a couple of others as we go through this presentation, you can reach out to us and we'll be happy to send this to you. The 2015 Specialty Registry reporting options are Prescription Drug Monitoring Program. CMS states we continue to allow registries such as Prescription Drug Monitoring Program reporting and Electronic Case Reporting Registries to be considered specialized registries for the purpose of reporting in the EHR reporting period in 2015. Cancer Registry, I know some of you on the webinar have participated in this or are attempting to participate in this because in many cases it's not ready yet and all you're really getting is to be accepted, and really you're just registering your intent at this point for 2015. EPs who were previously planning to attest to the cancer case reporting objective may count that action towards the specialized registry reporting measure in the years 2015 to 2017. But for stage 3, so that's optional in 2017 and mandatory in 2018, a specialized registry cannot be duplicative of any other registries or reporting included in other meaningful use requirements. So therefore, the cancer registry will not be eligible in 2018 or if you're attesting for stage 3 in 2017. So that's just something to keep in mind for the future.
Great, thank you, Cindy. So let's move on to public health reporting exclusions. What do these exclusions mean for a provider? An exclusion allows the provider to be excused from attesting to a specific measure based on certain criteria laid out by CMS they must meet. However, there is a catch. You can't just claim an exclusion for each measure because an exclusion for a public health reporting measure does not count toward the total of 2 measures needed to successfully attest. Instead, in order to meet this objective, a provider would need to meet 2 of the total number of measures available to them. Although for 2015, if the EP qualifies for multiple exclusions and the remaining number of measures available to them is less than 2, the EP can meet the objective by meeting the 1 remaining measure available to them and claiming the applicable exclusions. So there are 2 different types of exclusions. Standard exclusions, which are always in place and written into the final rule under each measure, and alternate exclusions, which are available based on the reporting year. First, we will focus on the standard exclusions that are offered. Let's start with immunization reporting exclusions. The EP is excluded from immunization registry reporting if the EP does not administer any immunizations to any of the populations for which data is collected by its jurisdiction's immunization registry during the EHR reporting period. If the provider operates in a jurisdiction for which no immunization registry is capable of accepting the specific standards required to meet the CERT definition at the start of the EHR reporting period. Or if they operate in a jurisdiction where no immunization registry has declared readiness to receive immunization data from the provider at the start of the reporting period. This means all of the registries are closed for meaningful use reporting. After the start of the reporting period, you must register your intent to report within 60 days. If you don't have registries that are capable of accepting the information or have not declared readiness, you will be able to exclude from this measure, which should not be the case since, as I mentioned earlier, every state should have an immunization registry up and running at this point. If you need to verify, you can take a look at that registry white paper Cindy just mentioned for modified stage 2 or your state's website. Syndromic surveillance exclusions. The provider is excluded from syndromic surveillance reporting if the EP is not in a category of providers from which ambulatory syndromic surveillance data is collected by their jurisdiction's syndromic surveillance system. if they operate in a jurisdiction for which no public health agency is capable of receiving electronic syndromic surveillance data, or if they operate in a jurisdiction where no public health agency has declared readiness to receive syndromic surveillance data. And then just note that in 2018, only providers providing care at urgent care facilities may use this measure. And lastly, specialized registry exclusions. So the provider is excluded from specialized registry reporting if the EP does not diagnose or treat any disease or condition associated with or collect relevant data that is collected by a specialized registry in their jurisdiction during the EHR reporting period. And then the last two are the same as the two for syndromic and immunization, basically stating providers without a registry option to report to, or if it's out of the clinical scope of their practice, they may be excluded. So moving on to these alternate exclusions. It's important to note that these are specific to each reporting period and depend on an individual provider's meaningful use stage. Their purpose is to accommodate the changes required for the transition to the modified stage 2 objectives and measures. So alternate exclusions for 2015 only. Providers scheduled to be in stage 1 last year must attest to at least one measure from the public health reporting objective measures 1 through 3. They can claim an alternate exclusion for measure 1, measure 2, or measure 3. An alternate exclusion may only be claimed for up to 2 measures. Then the provider must either attest to or meet the standard exclusion requirements for the remaining measure. EPs scheduled to be in stage 2 last year must attest to at least 2 measures from the public health reporting objective, measures 1 through 3. They may claim an alternate exclusion for measure 2 or measure 3 or both. CMS has also stated that they will allow providers to claim an alternate exclusion for a measure if they did not intend to attest to the equivalent prior menu objective. They did this because the agency issued changes so late in the year. But keep in mind, this is only for the 2015 reporting period. We will get to 2016 next. Basically, there are a lot of exclusions for the 2015 public health reporting period because they're really taking into account what a physician was planning to attest to before the final rule came out. So it really is a case-by-case situation when it comes to these exclusions. So to sum it all up, if you were scheduled to be in stage 1 in 2015, you may take up to 2 alternate exclusions and 1 standard exclusion. If you were scheduled to be in stage 2 in 2015, you may exclude from measure 2 and 3 if you didn't intend to do them under the previous rule. You may also exclude from measure 1 if you don't provide immunizations or a PHA is not available or ready to accept data. These alternate exclusions do not cover providers for this year, which means Objective 10, Public Health Reporting in 2016, all providers must meet 2 measures, no exceptions. Continuing on to this year, the 2016 EHR Incentive Program requirements were just released and posted on the CMS website last week, so this is the most updated information available. Like I said, many of the alternate exclusions that were available in 2015 are not applicable for this year. However, to assist stage 1 providers in 2016, there are 2 alternate exclusions that have been defined. Providers scheduled to be in stage 1 in this year may claim an alternate exclusion for an EHR reporting period in 2016 for Objective 3, computerized provider order entry, measures 2 and 3, so lab and radiology orders, or choose the modified stage 2 objective and measures. These are the only alternate exclusions being offered in 2016, in addition to the standard exclusions written into the final rule under each measure. That means all the alternate exclusions we just went over for public health reporting are gone, and providers have to meet 2 public health measures. So just in case you or one of your providers does qualify for an alternate exclusion, a lot of people are asking how they would know. Well, the Medicare and Medicaid EHR Incentive Program's registration and attestation system will automatically identify those providers who are eligible for alternate exclusions. Upon attestation, these providers will be offered the option to attest to the modified stage 2 objective and measure and the option to attest the alternate exclusion if applicable. The provider may independently select the option available to them for each measure for which an alternate exclusion may apply. So it doesn't need to be a global decision. If you are eligible for alternate exclusions, you can pick which ones you want to take advantage of and which ones you may not. All right, moving on to something a little different but along the same lines as exclusions, is this notion of a meaningful use hardship exception. So what is it? Well, eligible professionals who can participate in either the Medicare or Medicaid EHR incentive programs will be subject to payment adjustments unless they are meaningful users under one of the EHR incentive programs. As a result, EPs may apply for hardship exceptions to avoid these payment adjustments. So basically, it provides relief for meaningful use penalties. However, it does not replace any incentive payment that an EP forfeits. And hardship exceptions will be granted only under specific circumstances and only if CMS determines that providers have demonstrated that those circumstances pose a significant barrier to their achieving meaningful use. So EPs must demonstrate meaningful use every year in order to avoid Medicare payment adjustments. For example, a provider that demonstrates meaningful use for the first time in 2013 will avoid payment adjustment in calendar year 2015, but will need to demonstrate meaningful use again in 2014 in order to avoid the payment adjustment in calendar year 2016, and so on. To get a better idea of how much these penalties are, or how many EPs are subject to these a year, let's look at the penalties given out this year. CMS announced there will be 209,000 providers subject to a 2016 penalty under Medicare for failing to demonstrate meaningful use in 2014. CMS projects that based on the estimated Medicare claims volume, the majority of EPs will be subject to a penalty that is less than $1,000. CMS published the following breakdown of EPs and their expected penalties. Now, how to avoid these penalties through the hardship exception. So eligible professionals can apply for hardship exceptions to avoid penalties in the following categories. Insufficient internet connectivity. So the provider must attest to practicing in an area without sufficient internet access or facing insurmountable barriers to obtaining infrastructure. Lack of control over cert availability. The provider must attest to a lack of control over the availability of certified EHR technology in one or more practice locations where more than 50% of the patient encounters occurred. Lack of face-to-face patient interaction. The provider must attest to a complete lack of face-to-face patient interaction and follow-up, or that the cases of face-to-face interaction and follow-up were extremely rare and not part of the normal scope of business. Also, as a quick side note here, anesthesiologists, pathologists, and radiologists will receive hardship exceptions without applying based on their primary specialty. And the final hardship exception category is extreme and uncontrollable circumstances. In order to be approved for this hardship exception, the provider must attest to facing extreme and uncontrollable circumstances as listed below that prevented the providers from demonstrating meaningful use. The first being disaster. This is when an EP faced extreme and uncontrollable circumstances in the form of a natural disaster in which the EHR system was damaged or destroyed. Practice or hospital closure, which is pretty self-explanatory. Severe financial distress resulting in bankruptcy or restructuring of debt. And lastly, vendor issues. If a provider switches EHR vendors during the program year and is unable to demonstrate meaningful use, the EP may apply for an EHR vendor issue hardship exception and be exempt from the payment adjustment. Also included in this exception is the delay in rule publication. So this is for providers unable to meet the requirements of meaningful use for EHR reporting period 2015 for reasons related to the timing of the publication of the final rule. I actually took a screenshot of the hardship application in order to show you the exact wording they use. So providers that will be filling out and filing a hardship application due to the delay in the final rule should choose section 2.2D on the hardship application. And to add a little bit more confusion to the mix, we have this new streamlined hardship exception for meaningful use. So in previous years, providers had to apply individually for a hardship exception, valid for one payment year, and each application was reviewed on a case-by-case basis. Now, under this new streamlined hardship exception, providers would not have to meet such stringent criteria and qualifications, and their applications would not be reviewed on a case-by-case basis. So two acts that were unsuccessful in enacting a blanket hardship exception were the Meaningful Use Hardship Relief Act and the Electronic Health Fairness Act, but there was one that was successful. And that was the Patient Access and Medicare Protection Act. So this act expands the authority of CMS to grant hardship exceptions to meaningful use participants for the 2015 program year. They would allow providers who find it impossible to comply with the modified Stage 2 rule released into the final 90-day reporting period of 2015 to apply under the extreme and uncontrollable circumstances category. The legislation enables CMS to grant hardships not just on a case-by-case basis, but also to categories, with the deadline of March 15, 2016 for EPs, after which CMS would still have the case-by-case authority to grant hardship exceptions until July 1, 2016. So if we get very picky, the words blanket exception do not appear in the law as all the media reports claim. So there is by no means a guarantee that if an EP applies for this hardship exception, it will be granted. But good news, CMS has said it fully intends to grant hardships broadly based upon request. Basically, this new process permits group practices to submit a single application for all their providers and reduces the amount of information required. To take full advantage of the new streamlined review process established by this act, providers must submit applications by March 15th. However, CMS will continue to accept hardship applications on a traditional case-by-case basis until July 1st. And then just released this week was an updated frequently asked question regarding the hardship exception. The question was, on the new hardship application form for the 2017 payment adjustment, there is nothing which says documentation is required to be submitted with the application form. Does this mean that CMS will only require the selection of a hardship category and the completion of the provider's identifying information in order to approve a hardship exception? Or will CMS be reviewing the application and documentation on a case-by-case basis for each provider? And CMS responded saying, CMS does not require a provider or any groups of providers to submit documentation for the hardship category selected. And CMS will not be reviewing documentation supporting the application on a case-by-case basis. CMS will review the application to record the category selected and use the identifying information to approve the hardship exception for each provider listed on the application. Providers should retain documentation of their circumstances for their own records, but no such documentation is required for review by CMS. So providers who experience an issue with their cert related to the rule timing, and any other provider for whom the timing of the rule causes a significant hardship, should select subcategory 2.2D on the 2017 hardship exception application. No additional documentation is required for this selection. So the hardship exception application is now available on CMS's website with instructions. NextGen has said that there will be no need to provide hardship letters. CMS just said you don't need any documentation with it. And this application will allow groups of healthcare providers to apply for a hardship exception together instead of each doctor applying individually. This should make the process easier for physicians and their practice managers, and we're just happy everything is finally posted and is available for everyone. All right, so finally, our last section, Meaningful Use Subjective Updates 2016. I'm going to go ahead and let Cindy take it from here and help wrap things up with some program updates and changes that have gone into effect. Cindy?
As we started getting prepared for the attestation in 2016 for 2015, we started getting some questions, and one of the largest ones we had was the patient engagement clarification. In the final rule stage 2, the patient engagement, meaning your portal activity, was modified to mean that it was the first encounter of the patient during that reporting period. So for example, if you began using the portal in fourth quarter, or you were just you pick that as your attestation period. So you were doing the last quarter, October to December 31st. If the patient had been in the first week of October and you didn't give them the token until the second week of October, or you were using auto-enrollment and for whatever reason it didn't, the patient, it wasn't turned on, or you weren't using it for whatever reason, the patient didn't get the token until their second visit, even though they were offered the token, it would not count under the reporting rules. It is the first encounter during that quarter. And we had a lot of people who missed the numbers largely because of that. And we looked through it and worked at it, and there was really nothing around it we called CMS, and the bottom line is that was the rule. So if any of you are experiencing that, that's important. As we move into 2016 and you're doing a full year of attestation, keep in mind the same thing. If you have not engaged in that portal or in the patient communications, whatever method you're using to do that, if you're using a third-party portal or the next-gen portal, you really need to be cautious about the fact that it is the first encounter in that reporting period, and that means in 2016 the full year. Very, very important if you haven't done that to get that going. And we'll do another update to the patient engagement. Historically, meaningful use objectives requiring patients to take specific actions have been proven very challenging for EPs to meet. However, a recently published FAQ outlines a new calculation for these types of measures. When a patient of any one of the group's EP sends a secure message, receives educational materials electronically, or accesses via a portal their health information, any EP in that group can now count that patient towards their own numerator for patient action measures. So that's really important as well, because in the past, the way some of the reporting was is that if you had a pediatrician and they were working it, but you were a multi-specialty group, it wouldn't count because it was only for the pediatrician. They have softened that rule, and as such, that has made things a lot better. So this is actually one that is a really positive change to this measure. Updates to secure messages. For 2015 reporting period, the threshold that a secure message must be sent using electronic messaging of the search by more than 5% of patients changed to just having secure messaging fully enabled. So all you have to do is have it turned on. Now for 2016 reporting period, a secure message must be sent using CERT for at least one patient. It's a lot better than it was in the time when it was 5%, and it was 5% of those that had measured in the portal, and it relied a lot on the patient participation, which, as we all know on this call, is very challenging and a lot out of our control. We can do everything we want, but if we can't make them actually, we can take them to the water, but we can't make them drink, to say. Attestation update. CMS has updated its meaningful use batch upload page for the 2015 program year. Groups may upload all of its meaningful use attestation materials in one batch file rather than in separate files. When using this method, eligible providers will still need to independently register for their program or have someone else do that for them on their behalf. Additionally, each provider type, stage number, and measure category also requires separate submissions. CMS will accept submissions for the 2015 reporting year between January 4th, 2016 and February 29th, 2016. The attestation website is up and running. We did validate that. As we look at the vendors that have successfully achieved meaningful use with their programs, NextGen as a top performing vendor in meaningful use. So in this particular case, you can see that Epic, Allscripts, ECW, and then NextGen are the top 5 vendors that are doing this. What is really actually about this is that you see a few vendors on the screen, and to put it in perspective, there are 652 EHR and health IT vendors that play a key part in the data collection and reporting process. So while a number of other EHR and health IT vendors exceeded 650, according to the data from AUK, NextGen had the 4th highest number of total eligible provider attestations at 19,461. And I think that was important to mention because honestly, we really sometimes get asked, is NextGen really, is NextGen really doing this? And I know we've struggled with this with the updates and hot fixes. And yes, NextGen is really on the path to make sure that every provider that's working with it will remain current in a meaningful use way. So will meaningful use even be around in 2016? Earlier this month, CMS and the AMA convened at the 34th Annual J.P. Morgan Healthcare Conference to discuss the future of healthcare industry and the direction meaningful use is likely to take moving forward. CMS's acting administrator, Andy Slavitt, explained that the meaningful use program in its current nature will essentially end. Slavitt was quoted saying, "The meaningful use program as it has existed will now effectively be over and replaced with something better." I cannot tell you the number of calls, emails, and just conversations that I have had since that came out. We had individuals who were stopping their NG Share installations. We had groups that said, oh, it's going away, thank goodness. As I told all of them, don't get so happy so fast. I don't think that the government has done a lot in the past years to make it easier for us. So basically, Slavitt did not offer many details, but did say that more news would be coming in the next few months. He offered some insight into what this next phase would look like with a shift toward provider-oriented EHR use. As the Meaningful Use program progresses and evolves in these next few months, Slavitt points out the purpose behind these major changes, saying we have to get to the hearts and minds of physicians back. I think we've lost them. Well, that's a true statement. I think all of us that work with our providers know that no one is happy with these changes and some of the things that we've had to go through, particularly as it relates to some of the meaningless clicks and measures that you have to do for quality and all of the changes that have been made. However, we need to remember that nothing can happen without legislation. And legislators have already had their chance to get rid of meaningful use with MACRA and chose not to do it. MACRA regulations are intended to be released in 2016, which will change the program as we know it. But as of now, meaningful use is still part of the provider's MIPS composite score. CMS released a blog in response to the industry's reaction to the announcement, saying, what they really said was stop dancing in the street, slow down. The current law requires that we continue to measure the meaningful use of CERT under the existing set of standards. If MACRA does not eliminate it, nor will it instantly eliminate all of the tensions of the current system. We encourage you to look for the MACRA regulations this year. In the meantime, our existing regulations, including Meaningful Use Stage 3, are still in effect. So everyone take a deep breath and remember that we just keep moving forward, and eventually this will get better. I genuinely believe that. I think the change is going to continue, but not today. So reminders. HQM reports for 2016 are in development and are not available yet. There is a flexible date range report that is available if clients open a ticket with NextGen that will allow them to monitor 2016, but they are not the official 2016 reports. CMS 2016 reporting requirements have been posted on CMS website as of last week. Providers need to register their intent with 2 registries by February 29th, 2016. All returning attesters are reporting for a full calendar year in 2016. Don't lose sight of that. We're already in February, and it gets very, very hard to make these things up, particularly those things that involve patient engagement where you have to do 50%, and if the patients have already here, you've already lost your opportunity for the entire year if you haven't provided them that token or got them participating in some responsible methodology for communication between the patient and patient engagement. Are you uncertain where your practice stands? Let iTenif help by assessing your current readiness, providing recommendations, implementation of new processes and procedures. We are here to help, and you can certainly reach out to us at the end of this webinar. We'll be giving our email addresses and everything. Next steps, you can visit us at itenif.com. You can sign up for our informative webinars and blogs. You can consider our 3-day fixed price on-site consultations. We can do clinical workflows, revenue cycle, and front office workflow reviews, technology and performance, and then take a look at our website and test drive some of our products, Refund Manager and ChartGuard. So now for the question.
Okay. Yes. Wow. Thank you both for that. A lot of information, and it looks like we have a lot of questions already. So I'll start with the oldest ones, but please feel free to ask any more questions in the GoToWebinar control panel, and we'll answer them all. So first question, I've heard that the syndromic surveillance will not be available for EP after 2007, only hospitals. Is that correct?
I can grab that one. Yes, so syndromic surveillance will not be available to providers after 2017. It will only be available to providers working in an urgent care setting.
Okay, thanks, Lindsay. Next question. Is there a list of specialized registries for neurology? That way we can reach out to the register?
I can take that one. I'm sure there is. There's so many of these lists. We can take a look at the NextGen white paper, and we can also research this on your behalf and get back to you. These type of, I don't have all of these memorized when we get into specialties and states. We do know a lot of them. We'll answer what we can as we go through the questions. If we can't, we'll check it out and find out and email you later. We do have your email addresses, so we'll get that for you. I don't know off the top of my head where it is, but I'm sure there is.
Thanks, Cindy. Next question. If an EP registers intent and then finds the registry is not really appropriate, can they stop proceeding and move to a different registry?
Yep, I don't see why not. I mean, if you're realizing that the registry won't work for your clinical scope of work, you should be able to register for a different registry. You still have until the 29th. And going off that NextGen white paper, it's on NextGen's Knowledge Exchange for Objective 10, is really great. It actually lists registries by type and then it separates them by state. So that would be my first place for a lot of people asking questions of where can we find these registries. A lot of people are having issues just researching them and finding them. That would be my recommendation for that first stop of going from there, and then again checking with your state, and then again checking with any specialty organizations you may be affiliated with.
Thank you, Lindsay. Okay, next question. Is a valid response within the 30-day requirement that the practice is waiting for software upgrade before they can begin submitting?
Yep, as long as you, so I'm assuming you're talking about when the registry reaches out to you. They just want to make sure that you are responding to them and that they're not sending you messages that are going without any response at all. So as long as you have documentation that you did respond to them within 30 days, you should be fine.
Thanks, Lindsay. Next one. Does Dartnet require an interface?
That one I am not. Yeah, I was just going to say I'm not
looking.
positive.
I'm not 100% certain. I think it may be useful with NextGen Share, but I am not sure. I will look that up and get back to you.
I know a lot of different providers and clients are currently using Dartnet for a different registry as well, and you can use them for, they just released the patient safety one, so they do have, I believe it does require an interface, and they have different prices and deals going on if you use them for both of your registry reporting options. I believe is what we had researched and figured out, but we can get back to you on that as well.
And we'll definitely get back to you on it because it's going to depend on, there's so many different variations of the interfaces, and that one I don't know. We will get back to you. And as I said, any of these specific questions about specific registries, if we can't answer them, we will get back to you.
Okay, thank you both. Next one. What is recommended for OPH practices as the second specialty registry after 2017 since syndromic surveillance went away? Sorry, syndromic surveillance went away.
That is another one that we will look up and get back to you. There's several ophthalmology we work with several ophthalmology practices, and there's a number of them available. So we will get you a list and see what we can, assist you with on that. And that, I think, Stacy, you had that one. We will get that back. We will get the information back to you. Chelsea, it looks like we missed one as well.
I know. I just saw that, Cindy.
Okay, that's okay.
Yeah, no, go ahead. If a new interface is needed, are the interface enterprise or practice based?
I can take that one. NextGen,
okay.
Yes, NextGen traditionally has those interfaces as a practice-based interface. They have been, with certain entities and vendors, they have been making some, I don't want to call it concessions on that, but they've been making some, I would call it a volume purchase or volume deals with the interface company or the interface that you're looking to work with. So that would be something to reach out to your salesperson, but as a rule, those have been practice-based and not enterprise-based.
Thanks, Cindy. Okay, could the hardship exemption be requested if only one objective is not being met by a provider?
Yep, that's totally fine. If you're not meeting any of them, it doesn't matter if you're meeting one or all of them, apply. And make sure you apply before that March 15th deadline to take full advantage of that category hardship exception where you're just, CMS will just be checking your information and which category you applied for, so it won't be reviewed on a case-by-case basis. So again, that March 15th deadline is really important for providers applying for that hardship exception.
Thanks, Cynthia. Okay, would offering a token to a patient without them accessing their records qualify towards the measure?
If I can take that, yes, it does. You do need to offer them the token. You need to generate it, and then it gets marked in the system as pending. They do not actually have to sign up because that is active engagement. So you've done your part. You can't, again, it's back to the, leading the horse to water. You've given it to them, so it does in fact apply, provided that you have THR turned on in your portal. That's an important distinction. If you don't have that turned on, it does not apply. So that's something you want to check when you're looking at this. If that's turned on, it does apply.
Thanks, Cindy. Okay, do you know when Medicaid will be ready for attestations? Ohio MPIP.
If I haven't researched specifically, but it should be on Ohio's website. If they're not ready now, we can definitely reach out and look up on that. Although they should have all the information available on Ohio's website and should give at least a date range. If not, my best advice would be to call and see what they're planning and what they're waiting for.
Okay, for public health measures, can we do the same thing multiple years?
I can grab that one. Yep, you're totally fine too. That goes along with the same thing, that if you've already registered your intent with 2 registries last year or for a different meaningful use stage, then you're fine. So as long as you have 2 registries, then you can definitely, absolutely, if they're working for you and you're already submitting data, keep those. There's no requirements or mandates saying that you can't repeat, so you should be fine.
Okay, thank you. Next one. We are a specialty group who does not do immunizations, and our state does not accept symbiotic surveillance. Does this mean we have to register for 2 other special registries?
Yes, this would mean that, and I would suggest checking with your state or what registries are available with your specialty organizations and what their recommendations are. So even if your specialty organization doesn't have a registry, call them and ask what they recommend. So remember, an exclusion does not count toward your total for public health reporting. So you will still have to attest to 2 specialized registries if this is the case. Again, that next-gen white paper for the public health reporting is a great resource for that information.
We've went through this with a number of the practices we work with, and I can tell you in some cases they went for either the cancer registry if you had one of those in the state, and then you wait for acceptance, because all you have to do in this case is you, in the white paper will help you with this, is you just have to have registered your intent. They may decline you, so you'll never get to the second level, and at some point that probably won't work, but for now it does.
Okay, thanks, Cindy. Looks like this one's a helpful comment from one of our attendees. The neurology one is AXOM. They were very helpful, smiley face.
Yes, so thanks for that. The neurology one, so thank you very much.
Yep. What do you suggest when a provider, or what do you suggest when a new provider to your practice attested to Medicaid, and now with our practice we do not meet the required 30% MA patients to attest?
If that's the case, I mean, that just means they cannot attest under Medicaid. They would have to do Medicare, and because you have to take one of the programs, my recommendation to you is definitely first get that hardship exception application filled out before March 15th, and then look at and reevaluate all your options with attesting under Medicare.
I would definitely reach out to CMS on that. That gets a little tricky, and I don't have the answer. We can certainly look to see. That was from Charlene. We will definitely look to see something on that because it's an interesting question. But I would also definitely reach out to CMS and as Lindsay said, get the hardship application done.
Okay, thanks, ladies. And I just want to point out, I know it's 1 o'clock, but we still have a lot of questions to go through, so we're just going to keep going through them. If you need to jump off the call, the recording is going to include the questions, so you could always jump to the end where we're going to finish answering them. So if that's the case, thanks for joining us. Otherwise, stick around, and we're going to keep going through these. So next question: what is the realization that the registry is not going to work doesn't happen until after February 29th?
As long as you registered your intent, you will be fine, and you should you will have submitted the data, or you will have registered your intent before February 29th with the 2 registries. You should be meeting active engagement option 1. Afterwards, Cindy, did you want to make a comment?
No, that's just it. We were just going for the same answer.
Okay.
Okay, next question. We have registered with a specialized registry already. Can you provide a list of syndronic orthopedic registries?
We will look those up and get those to you if at all possible.
Great, thanks, Cindy. Will a PowerPoint be available for download? It sure will. In the next 2 days here, I'm going to send out an email with a link to the recording as well as to a PDF copy of the slide. And they're going to be available on our website under the Events and Education section, along with all of our previous webinars. So you can look back there in a couple days. Sometimes these emails tend to get clogged in your spam box, so if you don't see them in the next 2 days, definitely look there or always reach out to any of us. We'd be happy to send them to you. Okay, next question. If a physician became ill during the third quarter of 2015, can the hardship exemption be utilized for the EP? The certain provider is still not able to practice. So do you feel that we could justify that the final rules that we were given during the last reporting period did not allow sufficient time to attest?
I would say yes, you would still apply for that hardship application. I also want to point out there's another category for the lack of face-to-face interaction. I'm not sure how many patients your physician was able to see, or if they fell ill and were actually out and did not see any patients. That would also be another category you could apply under. So absolutely, the hardship application should definitely apply for that, and I would encourage you to submit it under March 15th. I'm just not positive which category to submit under. You may be safer this year doing that 2.2D, the extreme and uncontrollable circumstances category, just because a sickness combined with the final rule may be your best explanation. CMS is not requiring documentation right now, but just to keep on the side. So I would encourage you to apply under that 2.2D section. And then if you do receive a penalty notice in 2 years, you can actually apply for what's called a reconsideration form, and you have to choose a different reason for the hardship besides the one you put on your original application, and that's when you could actually change it to the lack of face-to-face interaction. So you'd have two shots at it, but you should be fine under the 2.2D application, hardship application reason.
All right, everyone, I'm going to have to jump off because I do have another meeting right away. Lindsay will continue asking the questions, and if there's any, Lindsay, that I need to address, I will get back to everyone. Thank you so much for attending the webinar, and I look forward to hearing the rest of the questions. Thank you.
Thanks, Cindy.
Thank you.
Okay, and clarification from the helpful attendee who gave us information on the neurology before. She said, sorry, neurology is with the AAN. As long as the provider is a member of the society, it's AXON. So thanks for that clarification, Polly. Appreciate it. Next question. We are an orthopedic practice, and we don't have a dedicated registry. However, if registries like Genesis accepts 1 or 2 measures relevant to optometry, do we need to sign up for it, or can we wait for optometric registry? Optometric registry. I can't say that word. Sorry.
Okay, so I know we've gotten a lot of requests for different, I believe Chelsea said it's ortho, correct, registries, so that's definitely on our list to look up for you guys and getting that to you. But if you have measures that they collect that do apply to you, then yes, definitely register your intent now while you can before that February 29th. I know it sounds very repetitive that we keep saying if you find out it doesn't work out after, no matter what, just register for 2 before February 29th. It puts you in that safe zone for active engagement option 1. But especially if they have a few measures that you are able to report to, then that should work for your practice. But again, we can also look up for your specialty any other options that may fit better for you. I would encourage everyone to contact their specialty organization, like we just had that helpful hint of contacting the neurology organization. So I would contact the specialty organization and ask their recommendations. But to get back to your question and answer that, you should be fine if you attest or if you register your intent before February 29th, and at least if you're submitting a few measures that apply to your scope of work, you should be good.
And sorry about that. I just want to clarify it was an optometric practice. I misspoke earlier.
Oh, okay. I mean, same thing applies. If you have measures that you're able to submit, you should be okay, at least for sure, to measure before that end of February deadline.
Thanks, Lindsay. Jason, we see a request. No problem. Charlene, we see a request for the surgical registries. We'll do our best to get all of these for you. Next question. I really got confused with the 2015 and 2016 requirements. Do we need to be actively engaged with 2 registries for both years or just by February 29th for the 2016 reporting year?
So thank you for bringing that up. I know it was difficult, and we kind of went through this making this presentation if we should just do 2016 alone and leave out 2015. But with that attestation deadline of February 29th, we wanted to include it. So let me kind of break it down. So for last year, for the 2015 reporting year, which was a 90-day reporting period, if you were a provider in stage 1, you only had to do 1 public health reporting option. If you were in stage 2, you had to do 2 public health reporting options. And those are what you are attesting to. And then, and then those you should have already submitted data. Now for 2016, no matter what stage your provider would be in, you have to do 2 measures for public health reporting. And you have to register your intent to submit that data for those 2 registries for 2016 reporting year within 60 days of the start of the year. So that's where we're getting that February 29th attestation deadline. So your 2 measure options that you're doing for 2016 are what you're registering for before February 29th of this year. So for 2015, it depended on your provider stage, but this year, no matter what stage you're supposed to be in, you have to do 2 measures, and you have to have at least your intent registered to them by February 29th to be in compliance for 2016.
Thanks, Lindsay. Next question. Are the meaningful use reports capturing the number of tokens offered to patients for electronic access? Our reports seem to have low numbers, and we are giving tokens all the time.
That would have to be a question for either Kathy or Cindy. For whoever's asking that, okay. I would write down their emails for that, just for the specifics on NextGen. But if you are issuing the tokens, again, I would look at if your PHR is enabled for the portal. That would be my first step. But if you're issuing the tokens, it shouldn't matter if they're actually accessing the information, as long as you're making it available to them, is what the rule specifically states.
Okay, so Leanne, we'll get back to you once we talk to Cindy or Kathy on that one. Next question. What if the realization that the registry is not going to work doesn't happen until after February 29th?
So I think this is kind of a repeat one. Again, you're fine. I wouldn't worry about that as long, again, as you're meeting option 1 and you're registering your intent to submit data before February 29th. Worry about that first. If it doesn't work out after February, you can change, but you'll still be covered by the active engagement option, and you'll still be in compliance to attest to the objective. So I wouldn't worry about that now. I think your first step would be registering your intent to submit data. If it does come back that you do need to find a new registry, you'll still be covered by that safety blanket and still be able to attest successfully.
Thanks, Lindsay. Okay, next question. Will incentive payments be made in full if attestation is successful?
Yes, I believe so. Just keep in mind that payment is 2 years delayed. So for 2016, providers are getting paid for 2014 right now.
Okay, next question. Does claiming a hardship exception affect incentive payments to providers?
Yes, it does. So when you claim a hardship exception, like I said, you are avoiding the meaningful use penalties, but you're also forfeiting any incentive payment you would receive.
Okay, next one. They do not allow you to change from MA to MC anymore.
Maybe that's a question for Cindy. I'm not sure what the context with that one or what that's referring to. Sorry.
Okay. Sorry about that, Charlene. We will get back to you on it. Next one. We have a physician whose specialty is behavioral health, Center for Child Development. She will be going live on EHR in March. So I have to have 2 specialty registries for her. She does not do immunizations, and syndromic would not apply.
Well, in her case, too, if she's just going live in March, I would actually submit a hardship application exception, and you can actually submit that under the 2.2D, but instead of, it would still be the same category, but instead of applying due to the late publication of the rule, you'd be applying with vendor issues, which means the basic explanation behind that category in the first place was if an EP is switching EHR vendors or is starting up on new EHR technology. So you can try and submit information if you want to try and attest this year, but I would go ahead and fill out that hardship application for that exception, and you should be fine and covered under that if she's not starting until March.
Okay, here's a great question from Karen. And I have to have this done by February 29th?
Yes, you do. It's a firm deadline. You have to register your intent 60 days within 60 days after the start of the EHR reporting period. I've had providers actually ask me to send them the formal documentation that's been published in the final rule because they don't believe me, but I promise you February 29th, you have to, at minimum, register your intent to submit data to 2 different registries in order to be in compliance with public health reporting for the 2016 reporting year.
Okay, Lindsay, compliment. Thank you for your expertise. You always do such a wonderful job of clarifying this confusing program. Yay, Lindsay.
Thank you. I try. I really do. Try and make it a little bit more fun for you guys, but I enjoy it, so thank you.
Okay, and it looks like this may be our last question. If you have any more, we'll be on for another minute, or you can always follow up with an email to the information that you see on the screen. And here's the question. The statement is regarding patient engagement clarification. Is this accurate for 2015 as well?
So for the patient engagement for the qualifying token, I'm assuming that's what you're talking or referring to. Yeah, so that is the case. The clarification was released by CMS, and it does apply to 2015 as well. I believe, I will double check on that. I'm sitting here second guessing myself now, but that yes, a lot of that's what brought it about for CMS to release the clarification, was that if the reporting period was October 1st, 2015 to the end of December 2015, providers were not offering tokens to patients coming in October, and they would come in later in December, and they would offer them a token, but the patient was unable to count in the numerator for the measure to help them complete the measure. So yes, this does count for 2015. I'm 99% sure. I can check that for you as well. But it is extremely important to make sure you pass along that information to your providers, that they have to give the opportunity to the patient and supply them with the token on the first qualifying encounter of the EHR reporting period. It won't count if they come back in.
So Catherine, to answer your question, yes, it must be given on the first visit. You're welcome. Okay, well, I think that that's it. So everybody, thank you so much for attending today. Hope that it was useful and informative. Lindsay, thanks for doing all the research for this. And again, we're going to post the recording and the slides on our website. We'll send out an email with that information. We also post it to all of our social media accounts, so feel free to follow us on Facebook, Twitter, LinkedIn, and get all the updates there, as well as tech tips and other great next-gen information. Thanks a lot, and have a great day.
Thank you again.